Welcome to the Low Carb MD podcast. No one is beyond help. No one is beyond hope. Nothing said on the Low Carb MD podcast is medical advice. Please consult your own doctor before making any lifestyle changes.
Hello and welcome back to the Low Carb MD podcast. Tro, we meet again. Good to see you, man. We got together last week, so we had a little break for a while, but we're back in action.
Yeah.
And we have a great episode today.
Oh my God, I'm excited about today. This is somebody whose work I've been following for years, who's literally a monster, I would say, in the biggest metabolic practice in the country. I am, it's kind of weird in the medical space, Brian. I know you feel this way, but like we have heroes, and it's like kind of weird calling some of your colleagues heroes. And you go up to them, you're like, oh my God, you're my hero. I'm just so enamored by what you guys have created and what you're doing. But the person we have on today is literally one of my heroes, right? One of my heroes. And I know when I probably say that, she's going to the imposter syndrome kicks in for all of us, I think, a little bit sometimes. But really, what we have today is a medical director of research at Virta. Her name is Dr. Caroline Roberts. She did her medical undergraduate education at Johns Hopkins, did internal medicine residency in endocrinology at Hopkins. And since 2016, she's probably reversed the most diabetes. Actually, I'm going to say this may be true. She's probably reversed the most diabetes in the world. Brian, that's who we have here today. So when I say I have my hero on, this is literally my hero. Dr. Roberts, I appreciate you coming on. And I'm going to turn my camera off for a bit. I'm going to step out and I'm going to let you guys get started, but I'm going to come right back and join the discussion. So you're my hero.
Awesome.
Thank you.
How does that? I'm just curious. Do you get the imposter syndrome like I do?
100%. Yes.
You should.
Yeah, you're humble. You are so nice and saying, we do a little bit over there. Virta Clinic has changed the world. It's really given us credibility for what we're talking about, and you have demonstrated when they say, well, it's non-sustainable. It works, but it's non-sustainable. But then you go, okay, here's our data and ongoing data. And so how do you go from an endocrinologist? It's so funny because of all the doctors I've struggled with the most has been endocrinology, because they're like, shoot insulin, just keep doing what you're doing. However much cookies you eat, just shoot some more insulin and everything will be fine. So how did you come from that world and start looking and saying, maybe there's a different approach?
Well, it was, I would say I've seen over the last 10 years, endos coming a little bit more toward our understanding of things. But I do agree with you. Like generally the idea is we'll add more meds. And I think, the distinction is clearly people with type 1 diabetes will always be on insulin. So we're never going to start talking about taking that away. That would be catastrophic. So what happened to me was I was in clinic and I actually had a pretty large type 1 population. I really enjoy care of type 1 diabetes. And it was on a cold day in February 2015 when a patient came to see me. He was new to me, young male, adult, type 1. And he, before I walked into the room, I took a look at his pump download with the CGM data on it. And I was like, that looks like my CGM data. And I don't have type 1 diabetes. It was between 70 and 140 almost 100% of the time. And this was for a week long data. And I walked into the room and I said to him, I don't know what happened here, but you've been misdiagnosed. I mean, don't worry, we'll get to the bottom of it. But, your blood sugar control is not really compatible with type 1 diabetes. And, he was kind enough to, not just get up and leave in that moment and tell me I'm an idiot. He said, no, I definitely have type 1 diabetes. I just don't eat carbohydrates. And I was floored by what he was able to do with his blood sugar control. I had never seen anything like it, anything. And remember, he was on state of the art, you know, on insulin, on a CGM. He had everything going for him, just like all my other patients. You know, I want to get them all on the best of care that's possible, but I just wasn't used to seeing outcomes like his. And so that was the turning point for me. And I kept that when I left the clinic there. I cut off his name, cut off any identifiers. I took that image because I should put it on the wall here because it changed my whole career. So he asked me a couple questions. He asked me, you know, how do I do this? And I, you know, and I said, well, I was like, well, it looks like you're doing it. Like, I'm not sure I have anything to add here, but he wanted to do it right. He wanted to do it well. And I didn't know how, you know, I didn't know what to tell him. I didn't know what he needed to do, what he needed to look out for, what might be signs of problems on this particular diet. I mean, I know with type 1 diabetes, of course, but like what specifically with this way of eating does he need to know? So that was what I needed to find out for him. But I also thought, well, what if I could help my other type 1s do this? I mean, don't they all deserve this? Don't they all deserve to have control like this? Because, you know, the rule for type 1 diabetes is just a permanent roller coaster of blood sugars. And you know, you never know what day you're going to have today. And you're always at risk for problems every minute of every day. And, you know, he was also at risk for all the same problems, but the predictability of his day-to-day life and his blood sugars, and I'm sure that played into his energy levels and ability to function in the world. I mean, people with type 1 diabetes, they're always dealing with the consequences of a high or a low, and you know it's exhausting and relentless, but he was not having that day to day, you know, or hour to hour, you know, wildness that people with type 1 diabetes struggle with. So I thought, well, what if I can help other people do that? How do I do that? And that led me down, you know, a road. I started learning about type 2, ketogenic diet for type 2. And ultimately, I cold called Sarah Hallberg, who was kind enough to take my call in the middle of a busy clinic. And she connected me with Steve Finney and Sami. And about 18 months after I met that patient, I ultimately, you know, joined Virta. Virta was really just in its very early stages at that time. I'm just in the clinical trial. I'm not even sure. I think they might have still been recruiting. I'm not sure that maybe they had completed recruitment. So I joined Virta in October 2016, and over the last decade have been you know, sort of inched my way towards the research team. And in the last 4 or 5 years have been mostly research. So I do still have a small patient panel at Virta, but I'm mostly on the research team.
Wow, it's just amazing. It's an amazing your story. And then, you know, so many people see something like that and they say, well, this is dangerous. You have to eat carbohydrates. I've heard that so many times when with my type 2s are out of control and they go in the hospital and they're getting tons of carbs with each meal and snacks and juice and all that stuff. So was that your first response, saying, how can you possibly cut out all your carbohydrates and survive and mentally function?
Not really, because it was so clear that he was thriving.
Yeah.
It was, you know, it is mystifying when you think about what patients are given in the hospital. And, you know, some hospitals do it better than others, but even out in the real world, what they do and what we were used to telling them. I mean, I was telling men, you know, 45 to 60 grams of carbs per meal, and women was more like 30 to 45. And that was just my shorthand of what I heard dietitians say. But, you know, we all want to be providing consistent advice. So that was what I shared with them. I also had, you know, gotten in touch with Richard Bernstein, and I actually spent 3 days with Bernstein in clinic. I can't remember what year it was. Maybe 2016 or 2017. And and ate with him. He would measure out all his plates of food a week ahead of time, and everything was measured. He's very much an engineer. And I got to eat he gave me some of his plates of food. So, and he did not call what he did ketogenic diet, but like, believe me, it was ketogenic diet, 100%. That may not have been his focus, and that's fine, but it was ketogenic. In terms of things like DKA, I don't know if you want to talk about DKA risk or like things like that.
Sure. Yeah. Teach us all your
absolutely.
stuff.
I mean,
Yeah, absolutely.
So, for obviously for type 2s, the risk of DKA, and at Virta, we generally don't take care of people with type 1. It's type 2 and obesity focused. But there is still risk of DKA in type 2s. And so, and when I first started at Virta, the SGLT2 inhibitors were sort of gaining penetration, and we're seeing more and more people with them. And our approach was to stop the SGLT2 inhibitor, a few days before starting ketogenic diet in order to, because of the recommendations to not combine them because of risk of DKA. But then all of this great data was emerging that they have cardiorenal benefits. And we were like, well, geez, we don't want to be depriving our patients who have those indications of those benefits. So should we continue these meds, and what would that look like? And so we made the decision that if you have one of those indications on enrollment, we would continue the med. But if you don't, we'll stop the med. And of course, then later down the line, sometimes we need to start a med, and that's on the table, especially for people with those indications. So but we also do finger stick beta hydroxybutyrate monitoring. So we have a pretty good way of detecting DKA. And so I published earlier this year our experience with DKA in our patients, and also if you look at the criteria for DKA, beta hydroxybutyrate above 3 on a finger stick or a lab value is one of the 3 criteria for DKA. And so we see that. I mean, we see that regularly, and sometimes we see it in people on SGLT2 inhibitors. So, but we also knew that a lot of them didn't go on to get sick. They did fine. So we wanted to look at our experience with DKA, and I have to say that in the process of that paper, we looked at what is the incidence in people not on SGLT2 inhibitors and in people on SGLT2 inhibitors. And I feel pretty good about our ability to manage patients on ketogenic diet and SGLT2 inhibitors, with the caveat that we're monitoring their BHB levels and we give them instructions, things, what to look out for, what to do if the number's high. And I think I feel comfortable with our incidence rate. It definitely increases the incidence of DKA, but I think it's a reasonable and manageable level that we see.
Yeah, I haven't seen any, we've been checking ketone measurements just to corroborate your findings. We haven't seen we have no evidence in any of our type 1s ever, nobody's gone into DKA.
Right, yeah.
And in our type 2 patients, when we think sort of the SGLT2 inhibitor is needed, which is rare, but very, maybe some renal condition or some cardiac condition where maybe it's justified, we've seen some modest increases in ketones, but we try to do it safely. We haven't seen anything worrisome. But we do counsel patients to say, if you're nauseous, vomiting, right, like the diarrhea, that maybe, it's time to come off the medication. I'm not sure that there's any evidence behind it, but it makes pragmatic sense to me. So I don't know, do you guys have a sort of what you guide patients on with these drugs, or how do you?
Oh, yeah. So we tell them, check your ketones every day before you take the med. If they're above 3.0, don't take the med that day.
Yeah.
Skip it that day. and continue to skip it till it drops below 2. Like, so if the next day it's 2.2, don't take it again. We want it below 2 before you resume it. And some people have really, really jumpy ketones, like really jumpy, and other people just don't. And I don't know why. I wish I knew why that was. And then for that day, we give them some reminders. Today, do not fast. This is not a good day to fast. Make sure you don't get dehydrated today, because these would be other things that could increase the ketones and tip them over into ketoacidosis. And also things like these are the avoidable causes of triggers of DKA. Of course, there's the unavoidable, like catch the flu or something that we can't control that. But this is not a good day to do any heavy drinking. Probably there's no good day for heavy drinking, but particularly not today. So we advise them on that, and then we ask them to check their ketones again and be on the lookout for symptoms. And the combination of potential DKA symptoms plus high ketones, in my mind, I'm not able to manage that remotely. You need to go, and I can't assess you remotely. I can't tell if you have an acidosis from here, so you need to go be seen. And in the early days, we would call ahead, especially for people on SGLT2 inhibitors, because sometimes if their glucose wasn't high, I didn't want them to miss DKA. So I'd call ahead to the ER and talk to the charge nurse. But I feel like they've, the knowledge has penetrated more deeply. I don't really need to do that anymore.
I'm wondering if during those studies, did you look at fasting insulin levels to see if they're at increased risk? Because some people just don't make enough insulin. And so they have they're going low carb, trying to lower their sugar burden so they can get more insulin sensitive. So I'm wondering if people who are really insulin resistant with very high insulin levels are less likely to get DKA. Have we seen a difference or looked at that?
Yeah, this was data from real world. So we weren't doing fasting insulin levels on people, but we did have C-peptide data on some people. So and it did not show, I have to pull out the paper to remind myself, but the C-peptide values, I'm pretty sure were not different in the people who had ended up with confirmed adjudicated DKA versus not. So, and on enrollment at Virta, because we are focused on type 2 and obesity, if we, sort of meet someone, we're like, you're looking kind of type 1-ish, based on their diabetes history, based on their weight and their autoimmune family history and a number of other things. Before enrollment, we will actually order a non-fasting glucose and C-peptide, and we have cutoff values that we would say we're not really equipped to care for you with our model of care. I mean, I would love at some point for Virta to, because I got started in this through type 1 care. I would love to someday be doing that, and maybe someday we will. But right now, that's not what we're doing.
Yeah, and the type 1 has been very interesting, because I've seen some of Dr. Andrew Kutnick's data, and it's very interesting. If he works out really hard, he gets really high sugar, so he has to shoot insulin before he exercises. So many athletes I see that the coach is like, well, you're going to go play baseball, so you got to carb load before you go out there. I'm like, I wonder, that seems counterproductive based on what we're seeing in Andrew Kutnick and some other patients I've had.
Well, I would say that it's it can be very different for different people, and also depending on the exercise that they're doing. So
the higher intensity exercise, like sprinting or something.
Competition versus training, there can be a very big difference between those two circumstances.
Interesting.
So you have to kind of get a feel for that person's pattern and then respond to it.
Awesome.
Yeah, I think I think type 1 is such a nuanced, I think unfortunately it's such a, I think type 2, let's sort of talk about the whole thing. Type 2, I think the ADA has sort of shifted its tone in terms of diet, allowing for low carb, thanks in part a lot of your work. And if I'm not mistaken, are you on a committee? You're on the, do you serve on a committee at the ADA, or did I make that up? No, okay, I made that up. Sorry, I was thinking Laura Saslow. But they've embraced, the ADA has to some degree embraced, low carb and very low carb diets. But I feel like in the endocrinology realm, type 1 is still it's still a very, it's not quite accepted to embrace a low carb or ketogenic diet. And which is unfortunate. I think it's the people who could benefit the most. I was reading Virta's report very recently on the amount of units. I think it was like, I don't know, 75 million. Does that sound about right? 75 million units of insulin saved. Does that sound right, Carol?
Yeah, I think that's what they said.
Right, that was the report. And like, imagine if we address type 1, how the decrease, we're seeing a 40% decrease in insulin utilization in our type 1 patients. And
amazing.
That glycemic variability is sort of stabilizing. So why do you think the endocrinology field, the ADA, why do you think they haven't, embraced sort of lowering carbohydrates in type 1? And I want to recognize the amazing work you did with, I'm fairly certain you worked on that paper with David Ludwig and back in 2018, right?
The pediatrics paper for type 1. I was not on it. I was not on it, but I love that they published that. Obviously, it's not going to change guidelines because it's a self-selected group, totally uncontrolled. But in terms of opening up the conversation about carbohydrate intake and needs, that was critically important, and especially for pediatrics to show growth. That was critical.
Yeah. So why hasn't the the American Academy of Clinical Endocrinologists, and why hasn't the ADA embraced? Like, what do you think it'll take to embrace low carb diets in type 1 patients?
Well, I think that in type 1s particularly, I'm not sure. I know that there is concern for children, particularly, and young adults, about them, feeling different from their peers at times in life where these are major concerns, and, going to a birthday party and not eating the food that's there might be, psychologically difficult. Creating eating disorders, I think, is a concern. Now, I think that we need to be concerned about these things? I don't know to what degree we need to, versus maintaining metabolic health for the child as they're growing, because they get insulin resistance as well. And, it's a very, very, I'm not trained as a pediatrician or a pediatric endocrinologist, but I do think some of the concern is rooted in the care of children. I also think that because the ADA and AHA, they have recommended diets that include a lot of whole grains and legumes and fruits, things that would not be on a ketogenic diet. I think that they are concerned that, and they've said these are the heart healthy things. So if you take those things out, and of course there's other aspects of their recommended diets, but if you take those things out, they're not heart healthy. And the big, we know that we see dramatic improvements across a broad range of cardiometabolic outcomes very consistently with ketogenic diet, but there is that concerning LDL rise that happens in some people. And, I think the concern that we have to answer is, what about cardiovascular outcomes, the endpoints, the clinical endpoints? Because, there have been people who have published, ketogenic diet will increase cardiovascular risk. It will increase cardiovascular events. I think it's critical to answer that.
You mean observational studies, right? You're talking about suggestions or hypotheses generated from observational studies, right? That's what's been published. I've yet to see an interventional study showing, worsening, cardiovascular risk. I think you guys, published your, 10-year cardiovascular risk reduction. I think it was like 20% or so, if I remember correctly. And
must be 5 years, yeah.
Right.
Uh-huh. It must be 5 year. I don't think we have 10-year data
No,
or
I
10-year
meant
publication.
the 10-year I think you guys did a pre and post 10-year risk
Oh,
calculator.
yes, ASCVD risk calculator. Yeah. Okay.
Yeah,
That
it
makes sense. Yep.
showed like a 20% reduction. I bet if you put in diabetes reversal, it would have been higher. Um, but now the new prevent calculators, I think, is a little bit more accurate. But I can't wait till we see 5-year data on cardiovascular risk. And I don't know if there's anything on that regard that you can share or not. But what are you seeing in clinic in terms of cardiovascular risk reduction? If there's something you can share.
In terms of risk reduction, like doing a risk calculator on people, we generally recommend the usual things, such as if you're not on a statin and it's, indicated based on your risk calculator, then we recommend you go on one. The other usual controlling blood pressure, all of the things you would normally do. Um, the problem is in our clinic, we don't have a control group. So if we were to look at outcomes in our patients, we can't compare that in our commercial population. That would take a study protocol or somehow have it, and that would be if it's a prospective study, that's a long study we're talking about, a long and expensive study. So even if that got funded today, we're years out from having outcomes. But if we do have some exciting work that hopefully will be go through peer review and be available to the public to look at some observational data. And I think it's exciting, and I think it'll start to move the needle.
Yeah, because I think we all know, right? If the 10-year, the AHA right now, it's grade 1 evidence for every clinician to do a 10-year risk assessment on their patients, right? And then now the 10 and 30-year risk assessment, the prevent calculator. So, we are, we shared the data at a meeting we were at recently, Caroline, where we did this. We did what the AHA asked us, and we demonstrated there was about a 50% reduction in atherosclerotic cardiovascular disease at 10 and 30 years using the prevent calculator.
Yeah. Yeah.
And we also showed that, and this is, in submission or pending submission, and a 68% reduction in heart failure. So,
Wow.
And this is which is, I'm sure you guys are seeing the same thing, and I'm sure. So, are the concerns about cardiovascular disease valid? Right. You mentioned there are concerns from observational studies, given these interventional outcomes, not outcomes, but maybe interventional pre and post. The data we have so far, the fact that out of, let's say, 25 cardiometabolic markers, 24 improve.
Exactly.
Right? So should we even pay attention to the quote unquote concerns?
I mean, I wouldn't be doing this if I thought that I were harming patients, right? I wouldn't be doing it. From what I see, everything gets better, except sometimes the LDL goes up, but not all the time. And then I guess the big question is, what do we do about it? Do we need to worry about it? How do we address it? But if I have people thriving and doing fantastically well by all the things that we measure normally in clinic, I would not be surprised if the cardiovascular endpoints and renal endpoints and liver endpoints and other endpoints all prove eventually to be better in our patients than in controls. I mean, I wouldn't be doing this if I thought that I were harming people, period. Like, no, I wouldn't be doing it. From the diabetes control aspect only, which is how I got into this, of course. that's like, the one of the main things that endocrinologists do is help people with type 1 and type 2 diabetes and all the other forms of diabetes control their blood sugar. And we also keep an eye on cardiovascular risk and make sure we're managing that appropriately. But I saw dramatic improvements in the glucose control. And in many of the other, like I had people coming off their antihypertensives needing to come off of them because now their blood pressure is running low. I mean, how wonderful is that? They don't need that medication anymore. It's once you see this, it's very hard to unsee it. And it does become, I share your sort of feeling mystified as to why this isn't more widespread and embraced by the societies. I wonder, have the people there not seen it, or do they not believe what they've seen, or I don't know.
I think it's not, and actually we should talk about this because there's three really smart docs here, and you just asked a brilliant question, which is, why do the other docs and seemingly very smart docs, these are well-educated people, and they publish research, and they certainly care probably as much as we do. Why do people, look at the same, things, maybe or maybe not see the same things? Why isn't there more embracing of metabolic health interventions in the AHA, the ACC, the ADA, even the AAP, the American Academy of Pediatrics? So I think we should all go around and answer that question. And maybe, Brian, you could start us off. And this way Caroline doesn't get in trouble.
I might get us taken down, Tro. Gosh darn it. But, obviously the big issue.
Caroline, you just asked a really important question to human progress.
Yeah, there's big issues, and I think a big part of it is pride. Like, you've been telling someone something for all those years, and all of a sudden you have to say, when I told you never skip breakfast or you're going to die and go into starvation mode, I don't think that's true when I start looking at the data and clinical outcomes. But the biggest thing, I think, is conflict of interest, because if I'm sponsored on this side by big pharma and this side by big food, I can't. As a matter of fact, I was on a show yesterday. Someone invited me on her radio program. We were talking about the dangers of processed food and sugar and all this stuff. But all the advertising on her podcast, on her radio show, was all for big food, and they come and eat all the cookies you want and you get free. And a caller called in and said, "Hey, isn't this ironic? You're saying how bad all these things are, and every commercial is advertising." He goes, "That's what we're up against." And you go, "Wow, this poor lady's probably going to lose half her sponsors." But it's a big issue with conflict of interest, and I also think pride of being able to say, "Yeah, I think we had it wrong. Let's look at," like Tim Noakes. That's why I like him so much, because he looked at it and said, "I was wrong. I was wrong. It's hurting people, so I have to change what I'm doing based on the evidence, instead of saying, I'm just going to die on this hill. I'm never going to change. I'm just going to disregard all the evidence that says I'm wrong." And I think that's a big part of it. Caroline, what do you say?
Well, I was writing down my thoughts so they didn't slip my mind. I think that you're right. I think it can be hard to say, I think there's a better way than what we've been telling you. That's hard. I also, I totally get what you mean about conflict of interest, and I share some of your, ideas on that. I do think, though, that people want to do the right thing. Like they want to. No physician, at least, any physician who should be out of jail, wants their patients to stay sick, right? They want their patients to do better. They want their patients to thrive. Maybe as you get away from individual physicians and into societies, like there is, you're right. Like there is like a reason why, professional societies might stand to benefit from ongoing illness, but I don't really believe that they're saying in any way, how do we keep people sick? Let's tell them to eat this diet that's not going to help them. So I don't know where I feel like there's a big gray area between I want my patients to do well, and I have this conflict of interest. That the gap between those is pretty wide, and it's not black and white. In other words, One thing that I have heard, and I'm sure you guys have heard this many times, is about sustainability. And also the outcomes over time. I mean, in the ADA, the 2025, this section that talked about ketogenic diet, they talked about um, it's as time goes on a ketogenic diet versus another diet, they start to look the same after a year, after 2 years. So that's one thing. I'm not sure I believe that. I think if you dig into the studies that have gone more than a year, what happens is they sort of follow the Atkins model where they add back carbs and I don't know why they do that. If you took a med that worked really well, would you study the med by putting them on it for 6 months and then tapering them off and then looking at the outcomes at 2 years? You would never do that. You'd be like, no, we want to look at the outcome of this med at 2 years or whatever time frame you're looking at. So I'm not sure why a lot of studies seem to be structured that way, where they start to add back carbs and then look at outcomes after the carbs are back. But the thought of I think the criticism about sustainability is valid because people do struggle. Some people struggle a lot. Some people don't struggle at all. And it can vary over time. So the first few months, there's novelty, there's excitement over your outcomes, and then, life throws you a couple curveballs, and the holidays come, and your auntie makes her famous dish, and you don't know you don't want to be rude. There's so many different ways that can throw you off. And so I do think that being on it consistently over time can be hard. And that's where I feel like programs like where they're doing remote monitoring and accountability like Virta and Tord are so powerful to help people really integrate this into their lives in whatever way looks best for them. I mean, I'm going to be eating a different way than someone else because of my, how I was raised, the foods I love. But I think that there are ways to do it very low carb across a wide variety of eating patterns. And I think, one of the things that I heard early on when I started telling patients about this was I got feedback was like, you're asking them to do the impossible. It's too hard. What you're asking of them is just too hard. It's not reasonable. Only doctors can do that. I was like, well, that may be, but here's a patient who's doing it. And just to make sure what I'm asking isn't unreasonable, I'm going to start doing it. And so I will be, this December, it'll be 10 years on a ketogenic diet. Definitely there have been times where it's challenged me, but I'm not sure it's that big a deal for a patient to have periods of time where they have less optimal control or they're less adherent. I mean, we know from studies in diabetes that the legacy effect of a period of excellent blood sugar control lasts for decades. So even if you did this for a short time and had a benefit and then went off of it later, you might still see the legacy of that for a long, long time to come. And that's incredible.
Yeah, if you forgot to take your metformin and then you just, got it refilled and started taking it again, like that's perfectly fine. It's better than maybe not doing that, right? Every doctor would agree. I think you're right. There's some entrenched bias against sustained dietary regimens, right? That people feel like it's not possible, and I don't blame them. Right.
Well, it's the same thing though, like exercise. You go, well, people just, they get lazy and they hurt themselves. They don't exercise. Well, so you don't tell them don't exercise. You say, well, let's do the best that we can. And like you're saying, and that's what I think is so great about a low carb or ketogenic diet. When someone who's diabetic, when they normalize their sugar and their insulin, their A1C, and then they do add some carbs back. I have people weekly that say add some carbs back. Like you're getting a stress response because you eat zero. I saw 2 people yesterday. And they're like, what do you mean? I go, your A1C is like 4.2. Your insulin's 1.8. Like, I'm not too worried about you. Your triglycerides and HDL, everything else is great. So don't be afraid. So sometimes you can go one extreme too much and be afraid and run 8 miles a day and never eat a carb, and you think you're going to die if you have a sweet potato or something, And so it's finding that balance. I think what works for you and what works for the patient.
Well,
Ultimately.
I wanted to stab Brian at the answer of, what is it, and maybe I could share a quick story. What is it? Why haven't more doctors embraced it? I did a recent debate with a vegan doctor, and the vegan doctor, what I figured out is very smart. He's a published author, right? And he said to me, Tro, you think that smoking is bad. And I said, certainly I think it's bad. He said, well, secondhand smoking is pretty bad too. I said, yeah, absolutely. I think secondhand smoking is bad. He said, well, meat has the same, signal in observational studies as meat does, as secondhand smoking. So meat is secondhand smoking. This is what they were trying to say. And I politely said, I understand that, doctor, but when you look at smoking and the signal of smoking, and you control for these confounding variables, like economic status, weight, other things, the signal still remains pretty strong for overall mortality and for disease-specific problems like lung cancer. Maybe it goes down just a smidgen, but still pretty strong signal. But when you do this for meat, it goes away. And I said, maybe we should reconsider your premises. And he said, well, it's still a slight harm. And I said, you're right. But I said, does smoking have any interventional data, showing that it improves, markers that are known to cause, or disease states that are known to cause? I said, look at hypertension. Hypertension, Laura Saslow showed that it is better than DASH, Mediterranean DASH, in a 4-month trial. Look at Caroline Roberts. She showed that, disease reversal is possible, right? And that type 2 diabetes improves, right? And we have, even the KetoMed study done by Gardner, which I wrote a letter to the editor against, showed that more medications are discontinued in the ketogenic arm.
I know.
Right?
Yeah.
So I said, if you look at glycemia.
And that was part of the protocol, I believe.
Yeah, correct. Yes, exactly.
What were they thinking?
I'm not the only one who's paying
I want to
attention.
point out, though, they also gave CGMs to both arms, which is a little weird.
Yeah.
Because we know that people will modify what they eat based on the CGM data, and they will. So I'm wondering, and also the Mediterranean arm was a low carb Mediterranean arm. Like, they did everything they could to bring these two groups together.
And only a brilliant scientist could understand the master of design that is Chris Gardner. Right. So, which I think it's very clear you're paying attention to what he's doing, and he's brilliant. He's a brilliant scientist. But I said, look at all these things. I told this proponent, look at all these things, right? Metabolic syndrome, calorie for calorie, Volek, showed that it improves metabolic syndrome. So it's not like introducing cigarettes improves all these other things.
Right.
And the response, at the time, I didn't know how to respond, but this is what I got. They said, well, Tro, you tell these people to do these things in its interventional trials. How do you know what they're eating, what they're actually eating? How do you know, maybe they're eating cruciferous vegetables and fish. He's like, you're just assuming they're eating more meat. This is what he said. And then I thought to myself, Caroline, and Brian, what are these robust observational studies? They're just guesses of what people eat.
Yeah.
Right. And so it hit me that it's selective nihilism. What do you think? Do you think my theory is right here? It's selective nihilism? Or, that's what I thought. That's my theory, that people get critical for ideas that are new or that they don't like.
Yeah.
But they embrace, sort of ideas that they like or they're used to.
Right. And I actually thought where you were going with this was different, and I thought you were going with criticizing sustainability on ketogenic diet. And I was like, well, let's talk about sustainability on a vegan diet. I mean,
Hmm.
like, wow, that's even more different than keto, in my opinion. I know some people who do a ketogenic uh, vegan diet, and
Eco Atkins, right? Yeah.
what? Yeah,
Eco
and
Atkins.
I admire them. Like, talk about eating differently than the rest of the world around you. They're really doing it, and if that makes them feel best and that's what they want to do, I think it's fantastic. And I'm sure you have, and we have lots of vegetarians in our patient population. So, I'm fine with that. I have some beef with some terms like plant-based because I'm like, I don't know, if you saw what I ate, you'd probably call me plant-based because I eat a lot of salad. I love vegetables. So
Yeah, I
I
saw
really
your
feel like
plate
it.
in DC. I saw your plate. There was a lot of vegetables on that plate, you know.
Yeah, yeah. So I am glad you noticed my plate.
What's
Yeah,
I
I
look at
love.
everybody's plate. I say, like, what is everybody eating? Sorry,
Right, right.
I'm a bit of a snoop. Sorry.
No, no, I'm glad I didn't take it personally, like I was personally being plate stalked or
Yeah, well,
anything.
my
Yeah.
my plate was like a mound of, a mound of meat. So, probably
Uh-huh.
seen me eat before.
Yeah, I've definitely gone in that direction for stretches of time and like it. But then I was raised on salads. Like I probably will never give up salads. One thing that we did, we did this study on new people for newly enrolling at Virta with uncontrolled type 2 diabetes. And our usual care model is finger stick glucose measurement. Of course, we have people on CGM, but that's not part of what we do routinely, or so finger stick glucose and BHB measurement. So we randomized these people to either the usual care with finger stick glucose monitoring or to CGM. So they would have a CGM for the first 6 months. And with the hypothesis that the added value of the CGM, they'll do better. And the
I
primary
saw the
outcome,
study. Yeah, I saw it. Yeah, it
yeah,
was great.
it showed no difference, which I think is amazing. First of all, we got s- and by the way, the control group wore blinded CGM at different intervals throughout the study. So we were able to look at CGM data from the finger stick group. And both groups did incredibly well, and they had dramatic improvements in their CGM metrics. And to me, that sort of the exciting thing, the Trojan horse of this study was we got to see CGM metrics in people adopting ketogenic diet who couldn't even see their CGM data. And they did just as well as the other group. And that is incredibly powerful because it means that we don't need all this technology. It means it's democratizing. It means that you can do this without it if needed. Now, I have tons of patients on CGM and I love CGM and I use the data all the time. So I don't want to make it sound like I don't think there's a role for it. I absolutely think there's a role for it. Um, I just think maybe it's not always needed. I mean, maybe it's needed, at 9 months where their resolve is flagging, they're up against, you
Mm.
know, the traditional meals of that time of year. Maybe in that setting it's valuable. Or people who got on track and then got off track, help them get back on. That
Yeah.
could be valuable.
And
But the
and I
other,
think it's very valuable if you do it for a few days before you start, and then you start low carb and you see the difference, and they go,
yeah,
"Oh my gosh,
yeah,
that says a lot." And
yeah,
also, like one of my good friends, he goes, "Doc, he's Italian." He goes, "I'm just gonna die a little younger. I'm okay as long as I get my pasta and my stuff." And his sugars, I go, "You're diabetic, man." He goes, "Well," I go,
yeah.
"Let's just put one on and just see." So in January, I see him, and his sugars are stellar, everything's great. And I said, "What happened?" He said, "I couldn't take it. Whenever I had cannoli, I'd see my sugars go crazy and all." He
Yeah,
goes, "I ate a steak and I see everything fine." He said, "I
right.
just couldn't take it. It wasn't worth it.
Yeah.
It bothered me to know I'm shorting it because I love my grandkids and I want to be around.
Right.
So
And I
yeah.
hear that a lot, like, well, I'm just gonna die and I'll go out
Hmm.
big. And I'm like, well, we all want to go out, quickly and painlessly. The problem is there's a lot of things that can happen between here and your last day. And you may not have good health during that time. You may have very poor health. And, yes, we all would love to have the big immediate death and be perfect up to that day. But that's not really what we're talking about when we're talking about disease prevention. We're talking about death rates and mortality and age and mortality, but we're also talking about your health span between now and then. The other thing that I want to mention about the Ignite study was we did uh, serial ASA 24. So it's the 24-hour food recall. And I don't know if you've ever done it. It's so annoying. It's so detailed. Like it won't let you get away with anything. And so we did that. And interestingly, so a couple things I think were super interesting about this. One is that, one of the concerns about ketogenic diet is you increase your fat intake and your saturated fat intake and your protein intake, which I don't know if that's a problem or not, but that's one of the concerns. Some people are worried about that. Well, guess what? None of those happened. The fat, saturated fat, and protein absolute intake in grams per day was completely flat. It was the same. Only the carb intake changed and it went down. So the percentages went up of all the other macronutrients, but the absolute intake was the same. So, and that's the way we teach it. Now, I know that in other studies where they've looked at like the Keto Med study, I think it went up, and Saslow's study, I think it went up. But the way we teach it, it didn't go up. So I'm like, well, if that's the worry, maybe we just teach it a little bit differently. But I'm not even sure we need to worry about it. The other thing was that we told people eat to satiety, like eat as much as you want. Well, I know this won't be a surprise to either of you. They ate fewer calories consistently. So, at 1 month, the calorie intake had gone down. It was about the same at 3 months and at 6 months. So, told to eat to satiety, they ate less. And that's amazing because if you tell someone to cut their calories and don't tell them how to combat, the hunger that eventually kicks in, they can't do it. It's very, very difficult. So I thought that was amazing. We saw sustained calorie reduction and we saw no increase, no in the absolute intake in macronutrients other than carbohydrate.
How far out do you look at those, 24-hour recalls?
That study was a 6-month study.
6 months, yeah. I suspect there'll be a slight normalization, but I wanted to come back to the CGM use because I'm a big proponent of it. I think in the setting of continuous care, it's like Virta's already doing an amazing job, right? I don't think a CGM is going to help. And I said this after I read your study. Immediately afterwards, somebody was like, "Look, CGMs don't work," and I was like, Virta's awesome. Like you're like comparing somebody who's grade A student, and you're like, does studying more help a grade A student, right? I think for the average person out there without a continuous or sort of continuous care model, I think the CGM has a place.
I agree.
And I wanted to know if you felt the same way or not.
I mean, I will never, I don't ever want to go back to care without CGMs. Like I love CGMs. They sort of started to appear when I was in, actually, I don't even think I saw any in fellowship. It was after that. And, I would never want to go back to a world without them.
Yeah, I think there's benefit. Once you learn it, you kind of know if you're doing keto forever and you're doing the same diet and you're on that plan, you go, okay. But the thing that has been really helpful for me, especially short term, is people can see the effects of stress if you're bitter with people, if you don't sleep, right? All these things will have an effect on glucose control, and so it's just really a good educational tool. But once people get it, they go, look, I react strongly to watermelon, but I could have blueberries and I'm fine, or strawberries. And then they can say, well, okay, this is a better thing for me going forward. And they just know what you kind of know what it's going to be, so you don't have to monitor for 10 years straight is what I'm getting at too. If you're in Mexico and you can't afford a CGM, you can't do it. You can still do it with finger sticks, or there's other ways to get around it.
So
don't let that be the barrier for you trying a new lifestyle.
100% cost, I think, is a huge issue. You can spend $100 and get a month's worth of CGM, but spend $100, you could have a year's worth of ketone measurements. So I think that's a huge, like in terms of sustainability, and feedback. So yeah, I 100% agree with that, Brian.
And so now with Virta, you have patients who've been doing it now for 8-10 years?
Yeah, we do. We have some people. I met a few just a couple weeks ago. We had a celebration in Lafayette, and patients were invited. That was so cool. And some of the study patients were there.
Very cool.
And that was awesome to meet them.
And do we have long-term data on them to see sustainability?
They 5-year data, right? We have 5-year data.
We have 5 years. Yeah.
I mean, that was the study extension. And I think to go look at 10-year data, we'd need an IRB approval because, they haven't agreed to have themselves, monitored like that, and we're monitoring them, of course, of care, but, not to go back and look at them and share data. So it's an interesting question.
And it would be interesting to see people who did it for 5 years and now they've been off the program for 4 years. Like how's their sustain? Did they learn enough to say, okay, I'm going to keep this lifestyle. This is kind of where I'm generally going to be.
Yeah. Well, we definitely do have people who leave Virta because they're fledglings. They're ready to leave the nest. They're ready to fly. And that's a fantastic thing. That's a really wonderful feeling. We definitely have patients who say, I got all I need from you, and I'm ready to go. And that's wonderful. I celebrate that.
Yeah, that's awesome because there's 30 people in line ready to take that spot that need the help. And so, having, and that's another thing, having a sense of community is so important. Tro and I do that with our patients, and the people who are just day one or seeing people who've been there for, it's kind of like when people go through drug rehab, they have people that went through the program or they're training, helping the new person because they can identify and they can help and go, yeah, I was in your spot, a year ago, maybe, or whatever.
Right.
So it's kind of cool that, to see people helping each other along through the process and wanting to give back to someone else.
Yeah, that's one of the aspects of the, Virta Care is that there's the community. You can, within the app, you can go into the community and it's sort of like a social media thing, and people are posting questions and struggles and encouraging each other, and it's really nice. It's very nice.
That's I got to say, I said it in the beginning here, but absolutely so grateful for all the work that you've done. I think Caroline, Brian and I, we sort of sit here, we get people to listen to us, and we're sort of front facing. And there's all these like huge stars in the dark horses looming in the back, and it's such an honor for me to be able to get people like you, out there, and I know Brian feels the same way. Like just to have people see the face of somebody literally reversing, diabetes and obesity on a systemic scale. I think, you may hold the crown for most diabetes reversed. That really may be an accurate statement. So, there's so many other champions too. Laura Saslow, we got to she won't do an interview. She's like, I want to stay out from it, but I'm so grateful that you agreed, and because you deserve the recognition. You really do.
And Troy, I want to because I think this is a bigger picture too, is by controlling the diabetes, obviously we're decreasing the cost of the system as far as bypass surgeries, the amputations, and chronic wound care and Una boots and all that kind of stuff. But also looking at the mental health part of it, from a dementia standpoint and Parkinson's standpoint, changing people's lifestyle is the biggest intervention we can do to prevent those things instead of blowing up your engine, then trying to fix it. Like, let's prevent you from blowing up your engine. So the work you're doing is so critically important. I think, and I think that with metabolic mind and seeing depression getting better, bipolar, we've had so many people we've interviewed, and it's mind blowing when you say, wow, like Ian Campbell, we just had on
a meta-analysis published in JAMA Psychiatry showing that a ketogenic diet decreases depression. And I remember, Brian, 8 years ago when you and I said this, and we had threats to have our license taken away. Right. So I feel vindicated.
Incredible when you're seeing it and you say, we're seeing this in clinic, and, we see people come back happier and laughing. And I just had someone yesterday, he goes, yeah, I've been doing this keto diet for 2 years. He's an attorney. He said, I couldn't go to trial. I was a basket case. I could not. He goes, now I walk in it like I own the place. Like, I don't have any anxiety and fear. I feel so confident. I'm so mentally clear. Before, I wasn't mentally clear. And you go, wow, that's amazing to see,
Yeah, it's been really exciting to see the work coming out of psychiatry, and of course, the epilepsy world has lots of experience with this for a long time. But it's been exciting to see, and I wish I had thought of it myself. Like, they should try it for mental illness, But I'm so excited to see the work that's being done, and that they got published in JAMA Psychiatry. That's pretty amazing. I do think.
Don't discount your own work. You guys have published, 2-year depression scores decreasing. Don't discount your own work.
Yeah. And by the way, 5-year work on that should be forthcoming.
That's exciting.
And then there's, I think that maybe in psychiatry, and I'm guessing it feels like they've been more embracing the diet or more excitement about it than what we've seen in diabetes and cardiology. But I think that may have to do with the fact that they haven't really had a prescribed diet for, psychiatric health. The way that ADA and AHA and NLA have recommended diets, and they've recommended these similar diets over a long period of time with a little bit of shift, but not much. Psychiatry doesn't really have that. So I think that they are embracing it because, and also so many of the conditions are refractory to treatment or partially responsive. And so to see really dramatic improvements must be, I feel like they're having their index patient moment the way I did 10 years ago.
Yeah, it's exciting. It's exciting to see, because it was a side effect that we were seeing. We were saying we're trying to treat diabetes and saying people are happier and laughing and engaging more and going for walks instead of feeling like I have to exercise to lose weight. They feel like, I feel like going for a walk today. And the whole perspective changes, and this whole food addiction problems, and so many things that if you're enjoying life and you're not in pain all the time, you don't have to turn to these things anymore. So yeah, what you're doing is amazing work, and it'll be fun in 5 years to talk about more data and more things that are going on and what you're up to. And so thank you so much for joining us and sharing what Virta, because really Virta opened the door for us, because when those big data came out, we said, well, they're proving all this stuff we're and they have the money to do it. We don't. So yeah, we greatly appreciate your work, and we're glad to be under your umbrella.
Yeah, it gave us confidence. We were doing it, but it was 8 years ago, Brian, it was like we were in the shadows a little bit, right? Like we had to sort of hide. I remember, calling up Brett Scher 8 years ago saying, how much insulin should I reduce? Yeah, it's you gave us like the courage, and it's not easy to do. I'm grateful for Sami also, right? For bringing leadership here, and making it a place where you can work and we can all work. Like as a business owner myself, and I know Brian feels this way too. We're both business owners, and we want to create those sort of economic environments and be leaders like him to make places like this, because we have an entire country to heal. I mean, it's a disaster. Right. We're going to need 50 Virtas, right? So there's a lot of work to do here, and I just am thankful for you and thankful for Virta, and just everything that you're doing and continue to do. Thanks for having passion and being real.
Well, I am so excited to hear about what you guys are doing and to see your growth. And, just as you were talking, I was like, you know what? It's like having great neighbors. Like we're like in the same space and you're great neighbors, and it's just wonderful to see your work.
Yeah, we're your neighbors
You
from
don't
the
know
other
us
side of
well
the
enough.
tracks.
I'll come out with my underwear, pee on the trees, so like,
But thank you.
I think it
Thanks
is true.
for joining us. And Turo, good to see you, man.
Yeah, thank you. Thanks to all of you. Caroline, if somebody like a researcher out there, or
Yeah.
I don't know, I don't think you're too active on social, but if you're active on social, we're going to put all of the papers, some of the papers that we talked about in the show notes. We'll work with Jack to get that up. And you probably don't want our listeners contacting you, but if there's a contact info, we'll certainly share it in the show notes so people can reach out to you.
Great.
All right.
All right. Well, thank you so much.
Thank you so much. Thanks for joining us. We look forward to more of your work coming out.
If you enjoy the show, please consider supporting us on Patreon by going to lowcarbmd.com.